Welcome to lecture for Psych 310. We'll be talking about the sexual and gender identity disorders. Starting off, I think we just need to begin the discussion with what is normal sexuality. This chapter, the things we're talking about are basically manifestations of pathological sexuality. It's hard to understand what's pathological if you can't understand what's normal. So how do you figure out what's normal? And so what do you think is normal in terms of sexuality, both in terms of sexual attraction, sexual behavior, sexual identity, maleness and femaleness? What's normal? If we think back to how we figure out what's normal, we have a couple of things that can help guide us in our thinking. Not necessarily answer the question, but help guide us at least would be in terms of statistical deviance. So things that only a few people do might be considered abnormal. And so there may be some problems with that from a scientific point of view anyway, in terms of if something is always abnormal or if it's subject to change, because some sexual practices may become more or less popular with shifts in culture across time. If we look from one geographic region to the next, it's now common to see vastly different sexual practices. So in some degree, using statistical deviance to measure the normality of sexuality is a bit relative. Another thing that we look at is the degree of distress associated with any kind of behavior or pattern of behavior, thoughts, and feelings, in terms of figuring out if it's normal or not. And typically think, well, if it causes distress, then maybe it's not normal, maybe it's abnormal. So if you're not happy with something about your sexuality, your sexual orientation, your sexual identity, that might lead us to think, okay, something's going on here that might not be normal. But something to think about is, well, what if your distress doesn't come so much from just you being unhappy with how you feel, but your distress is a result of an intolerant society, such that if you move from one place to the next, your distress would change, right? So think about sexual orientation, for example. If you were living in Lubbock, Texas, and you had a homosexual sexual orientation, you very well might experience a high level of distress. Not the most accepting community in Lubbock of the LGBT folks, with some exceptions. Versus if you lived in Austin, you might experience less distress, a more accepting community of differences in sexual orientation. So again, even distress can be relative to time and place. And then the other major thing we think about in terms of determining normality, abnormality, is dysfunction. So if it's causing problems. And one thing we think about in terms of sex is, there are biological processes associated with sex, and specifically sexual behavior. So dysfunction could be about some problem with these processes, but the biological response of the sexual response cycle isn't going the way it should. We'll talk more about it in a bit. But then also there's an expectation that one of the psychological functions of sex is to provide pleasure. And if it's not providing pleasure, then that's also thought to be dysfunctional. It's not doing what it's supposed to do. You're supposed to feel good about doing this. And if you don't, then that's something's dysfunctional, possibly abnormal about that. Also, and this is kind of back to that relativity, depends on where you live, if your sexual behavior causes you to violate the agreements of a society, the laws typically, or causes you other problems, maybe relationship difficulty, then that is dysfunctional as well. Right? So if your sexual behavior, feelings, is causing problems in other areas of your life, causing problems with your romantic partner, with your family, with the community in which you live, that is dysfunction. Just as if you lived maybe in a community that valued recycling, and you didn't care about recycling at all, and you frequently took your aluminum cans and threw them in the regular trash in front of everybody, that would piss a lot of people off, and that behavior would be dysfunctional for you in that setting. So we can say the same thing about some aspects of sexuality. In certain settings, they may be dysfunctional. So For all the things we've talked about, statistical deviance, distress, and dysfunction, for sexuality and for other aspects of human experience, defining normality, as we kind of talked about here, is relative. Depends on where and when you live. If it's normal or abnormal, because it's usually compared to either the group or rules established by the group, the majority of the group. But in terms of our group, from Western culture, and our understanding of normal sexuality, another thing to think about is, are there differences for women and men, gender differences in normal sexuality? And there are a couple of things, and again, as with most things, when you compare women to men, you'll find that women are more different from each other than they are different from men. Men are more different from each other than they are different from women. So think about, if you were to graph out the behavior of men and the behavior of women in like a distribution, like the normal distribution of behaviors, where most men are average in whatever number of sexual partners they prefer. Right? Some men prefer more, some men prefer less. Look at the same thing for women. So there's an average number of sexual partners a woman might prefer. Average number in the middle, some more, some less. So you have these two distributions, these two curves. If we place them on the same graph, you would see substantial overlap between the two curves. There will be a difference in the average, but there's significant overlap such that some women prefer more partners than do some men, and some men prefer less partners than do some women. Okay, so lots of variability, but there are some average differences. Men tend to show more sexual arousal and desire than women. In terms of physiological measures of arousal, if we show men and women visual stimuli, typically, that's thought to be sexually arousing, men will show greater levels of arousal, greater blood flow, more increases in heart rate, all those sorts of things. Do men experience more arousal and more desire? Hard to say, right? Because arousal and desire, once you get to kind of the construct level, is it's impossible to measure directly. We can measure the indicators of arousal and desire, by heart rate, but in women, their level of desire may not manifest in increased heart rate, so it may be manifest in a different way, and so it's hard to really compare the two. But in terms of physiological measures, men show greater arousal and more desire for sexual intercourse and sexual activity than women. There's a tendency for women to put more emphasis on the relational context of sex than men. Men's sexual self-concept, how they see themselves regarding sex, is more tied to power, independence, and aggression, versus women's being more tied to relationship. And then women's self-concept and also their sexual orientation is more malleable than men's. So how a man sees himself as a sexual being and what type of person he's attracted to is much more rigid, much less likely to change across his lifetime than that of women. Women seem to be more likely to change, more able to change in response to changes in their environment. Okay. So when talking about sexuality, normal sexuality, one of the things that always comes up is talking about sexual orientation. But unfortunately, there's usually a lot of misunderstandings about exactly what sexual orientation is. So for a minute, just kind of think for yourself, if you had to provide a definition without looking up in your textbook or Googling, how would you define sexual orientation? For a lot of people, they define it as it's who you have sex with. But for researchers and most therapists, that's not a sufficient definition of sexual orientation. Who you have sex with is your sexual behavior. And your sexual behavior may or may not be consistent with your sexual orientation. Right? There are lots of reasons to have sex with somebody. One of them is that you're attracted to them. Right? There are plenty of others. The easy example that comes to mind is when we look at people that are put in confined spaces, prisons, and if they have they may have a heterosexual orientation when not in prison, but they may demonstrate same-sex sexual behavior in prison, both men and women. And not necessarily, some say, oh, well, yeah, rape doesn't count because they're not willing. And unfortunately, our instance of rape in prison is as tragic there as it is outside of prison. But there are also non-rape scenarios, usually involving some level of, or often involving some level of coercion, especially in male prisons. But nonetheless, there are sexual behaviors that take place that are, people see the prisoners themselves report as being inconsistent with their sexual orientation. So they maintain, I'm not, I don't have the same sex, I'm not bisexual, I'm not gay. But yeah, did you have sexual relations with this other man? Yep, but it's a separate thing. And so your sexual behavior and your sexual orientation, not the same thing. They're frequently correlated, but not the same thing. Another example we see, these politicians who are frequently married and have kids, and then scandal erupts whenever people find out that they're also having, usually it's men, having sex with other men, and that they, some of them come out of the closet and acknowledge being gay, but they had sex with their wife and maybe other women due to societal pressure because of an expectation to demonstrate certain sexual behaviors. But those sexual behaviors were inconsistent with their sexual orientation. So you say, okay, well, I get it. It's not behavior, then it's who you want to have sex with, right? It's who you'd like to have sex with. Well, that's not quite it either, right? That's sexual preference. And that has to do with just your preference for sexual intercourse, for one aspect of interpersonal relationships. And if we think of it that way, then you might say that children have no sexual orientation, right? Because you have a kid, you want to have sex with that other person? It should be a gross question to ask. Usually they would say, ooh, no, I don't want to kiss boys or girls, that's nasty. So does that mean they lack a sexual orientation? And they don't only develop an orientation later in life, and we don't know what it's going to be? We don't think of it that way, right? Because sexual orientation, even though sex is in the name, isn't just about sex, right? If you consider yourself heterosexual, for example, you probably don't define your heterosexuality simply as, yeah, I like to have sex with people who have different genitalia than me. Right? You may even be offended that people would say, oh, that's what it means to be heterosexual. No, it's more than that. But typically, majority groups define minority groups in simpler terms than they define themselves. So, sexual orientation is not as simple as behavior preference. Instead, it seems to be more two things. One, part of your identity. Right? It's not just about sex. And your identity is multiply determined. Right? If you're somebody who likes to read books, people might call you a bibliophile. But we usually don't go around, asking, hey, are you a bibliophile? I heard you might be a bibliophile. Or treating people differently based on what activities they like to engage in. If they like to watch movies or read books or drive fast. Right? We don't classify people along those terms. As a society, we spend a lot of time thinking and talking about this one aspect of our lives, about sexual orientation and sexual identity. But it's just one part, of course. So if somebody says, oh, you're heterosexual, okay, now I know what type of person you are. You would, again, probably be offended because, no, that's a part of who I am, but you don't know this, and this, you don't know all these other things about me. But again, a majority group often simplifies what things whenever looking at minority groups and saying, okay, you're a homosexual orientation or a bisexual orientation, okay, now I know what you're like. You have these characteristics, right? Which is stereotyping and oversimplification of the human experience. So it's just part of an individual's identity, regardless of what their orientation is. So what is that part of their identity about? Well, most researchers agree generally on the following definition, that it's a pattern of emotional, romantic, or sexual attraction that's typically defined by the biological sex of the objects of attraction. Okay? So it's about sexual attraction, but also romantic and also emotional. So if you're have a heterosexual orientation, then that means that you're sexually attracted to people of the opposite sex. It also means you're emotionally attracted. You want to be intimate in a way emotionally with people of the opposite sex, that's different than the way that you're emotionally intimate with people of the same sex. It's a different, sometimes a different level, but frequently a different type, different quality of intimacy. And that has to do with what we grossly call your sexual orientation. Right? And that emotional intimacy may or may not be related to sex. Right? You may have some, if you're heterosexual, you may have some opposite sex friends who you don't have sex with, but your relationship with them and your pattern of emotional attraction to them is different than with your friends of the same sex. Right? And same thing for people of homosexual orientation. They're sexually attracted to people of the same sex, but it's also this emotional attraction, and it's about being intimate and wanting to share of yourself and know them in a kind of emotional way that's not limited to sexual behavior. And it's interesting that this pattern of emotional romantic sexual attraction, again, something that we define by biological sex, because everybody has different patterns of emotional romantic sexual attraction. Right? We usually talk about it in colloquial language as what's your type, right? What kind of person turns you on, gets you excited, are you attracted to? And people have different answers. Oh, I like people who are tall, I like people who are short, I like people who have darker hair, I like people who have lighter hair. Everybody has their own things that, for whatever reason, whenever they get those visual inputs, something goes off in their brain, and they think, yeah, that I find that person attractive. And somebody you grew up with and yourself had similar experiences may find two different people attractive, right? Which is usually good if you're friends, if I was the same person. But the point is, we could define it by these other things. Oh, okay, so you're a person who's attracted to tall people. You're a person who's attracted to short people. But we don't. For whatever reason, we've chosen to define it by the biological sex of the person attracted to you, and not other characteristics. But there are other characteristics that play into your attraction orientation. But again, we usually have a limited understanding of it, just looking at one aspect. Okay, so now that we've kind of defined what sexual orientation is, my next question to put to you is, should sexual orientation be a diagnosis or be used as a diagnosis? So, should there be, a heterosexual behavior disorder, or heterosexual orientation disorder, or homosexual orientation disorder, or bisexual orientation disorder? At one point in time, there was homosexuality was listed as a psychological disorder in the DSM-3, taken out with the DSM-3R, I believe. So at one point in time, it was considered pathology, right? Which, from the old model of the DSM, means a disease. Condescending, most people wouldn't say disease, but still pathology, a syndrome, a pattern of behaviors associated with distress or dysfunction. Does that make sense, given the definition of sexual orientation we were just talking about? Looking at it and thinking about the other disorders and the other criteria, taking away kind of ethical, cultural arguments, just looking at how things are categorized and diagnosed. Generally, we don't pathologize patterns of attraction or thoughts. Generally, the focus on diagnosis is you exhibiting these behaviors, and they're causing you some problem or dysfunction. And if we put sexual orientation in, then we are now pathologizing the way someone feels about other people, an interpersonal approach. And if we do that, then might not it also make sense to put in a disorder for indiscriminate heterosexual disorder, where heterosexual men who seek out multiple sex partners with little regard for the feelings of their partners or safety concerns, right? So they don't use condoms, perhaps. That sounds pathological. It certainly could lead to dysfunction. They're at risk for getting venereal diseases. They're not establishing a healthy monogamous relationship, which is a cultural expectation for us anyway. So there's dysfunction, may not be distress, and probably some statistical deviance once you get to a certain number of partners. Or alternatively, you can have a disorder that says people who choose to only have one sexual partner for their lifetime. So that's weird, which in some ways, unfortunately, is statistically deviant today. The number of people who choose to have one partner over their lifetime is shrinking. But that might be indicative of some sort of unnatural fear of sex and a failure to develop a healthy repertoire of sexual knowledge and behaviors. Right? So we could pathologize that as well. So if we start pathologizing sexual behavior, you can kind of see there's this slippery slope that, depending on what the majority in power thinks is right, they could easily abuse their power by just pathologizing anything that they're uncomfortable with or disagree with. So the research evidence doesn't seem to support sexual orientation as a disorder. It doesn't. When we look at measures of sexual orientation, it doesn't act the same way other disorders act at a kind of taxonomic level. But ultimately, all disorders, including this one, at some point come down to being influenced by cultural values. Right? We like to pretend that depression is this thing that's out there, and there's no cultural assessment of anything. It's just something that it's just like malaria. We didn't make malaria. It's this thing, and we're just identifying it. But for psychological disorders, there's always this cultural component where if people were comfortable with expressions of sadness, and they thought that it was appropriate for people to be extremely sad or apathetic at some times in their lives, and we said, okay, well, that's how you are right now, that's acceptable, then it wouldn't be a disorder. But as a collective society, we said, we don't think that's right. And in some ways, well, it causes dysfunction, you can't go to work. Well, who says you have to go to work? Society says you have to work. So there's always this cultural angle there for any disorder, including sexual orientation. But most researchers currently, as is evidenced by the absence of a sexual orientation in the DSM, don't believe that it should be used to diagnose people, and it is not pathological. Okay, moving on to development of sexual orientation. How do you get to be that way? So, what's the cause of a heterosexual orientation? So for those of you who have a heterosexual orientation, how did you get that way? What happened to you? You think, well, I was born that way. I was made that way. Well, how do you know? How do you know you were born that way? Well, because people of opposite sex, they make babies, and so it makes sense. Yeah, but that would make sense, and would be a better argument if people only had sex to procreate. People have sex and engage in various sexual activities that don't involve the possibility of procreation, certain sexual activities that wouldn't necessarily result in reproduction, but are about pleasure seeking. Right? So there's no biological reason for an exclusive sexual orientation. Right? And in some ways it makes more sense from an evolutionary perspective that if there's some behavior that results in pleasure, that you would seek out pleasure from any partner that would avail themselves to you. So it's too simple to say, oh well, it's biological. Yeah, probably in some ways, like everything about you is influenced by biology, including your sexual orientation. But we take for granted that heterosexual orientation is some sort of natural or right way as determined by biology. But that's not supported by logic. From an evolutionary standpoint, it does make sense that people who were more geared toward people of the opposite sex, who had more sexual interactions with people of the opposite sex, would have reproduced more, and thereby passed on more genes associated with being attracted to the opposite sex. But there are also kind of evolutionary arguments that can be made for why certain people would still, why the genes for being attracted to people of the same sex would get passed on as well, in terms of both the sexual attraction but also the emotional attraction to people of the same sex contributing to the increased availability of resources, which lead to the increased likelihood of survival of offspring, which also lead to the passing on of genes. Okay. But probably biology's in there somewhere, genetics, right? So it's probably biology and it's probably environment. For those of you who are heterosexual, why you are that way. Those of you who are homosexual or bisexual, why you are that way. It's a combination of genetics and environment. Like everything else about you, everything about your identity, how you feel, what you do, what you think. It's a combination of genetics and experiences. Right? And by experiences, I mean both what you see, hear, smell, and also environmental input experiences in terms of the gravitational pull of the earth, what food you eat. All those things are experiences. So some specific theories looking at the development of sexual orientation, which typically focus on the development of homosexual orientations. Again, the assumption being that heterosexual is the default, and then that something different must happen for homosexual orientations due to just the statistical difference in how many people are heterosexual versus other sexual orientations. One of the theories to explain a homosexual orientation would be in utero hormone exposure. So one of the things that pieces of evidence for this is if you look at your ring finger and your pointer finger and you measure them, and not just hold them up to each other, but you measure each one from the base to the top. Individuals that have a longer ring finger than pointer finger, that tends to be associated with, theoretically, higher exposure to testosterone in utero, right? Because finger length is determined at the time whenever androgenation of the fetus occurs, right? Because we're all born women, basically. And then for people that get a Y chromosome, at some point during development, androgens, testosterone are released, and you become sexually differentiated and become male. If that doesn't happen, then you continue to look female, which we have some of the differences. People that are intersex, whether they're XY but don't develop full male genitals because lack of exposure to the hormones. But anyway, so if you have the longer ring finger, that usually has to do with exposure to testosterone, and it's longer in heterosexual men. The ratio of ring finger to pointer finger is bigger in heterosexual men than in homosexual men. And it's not true for all men, so there are some heterosexual men that may have a shorter ring finger, and some homosexual men that may have a longer ring finger. But in general, there's enough of a difference to find a statistically significant difference. And the same thing, looking at not all lesbians, but lesbians who score higher on measures of masculinity, so masculine lesbian women who score higher on BIM's sexual inventory, who are identify more with masculine attitudes, tend to have longer ring fingers than heterosexual women. Other things, the hair whorl, which way if you look at the top of somebody's head, there's a kind of a whorl or a little spiral. It goes to the right or the left, clockwise or counterclockwise. And the direction of the whorl is associated with hormone exposure. And there are some differences between, again, gay men and heterosexual men in the direction of the hair whorl. From animal studies, looking at, we can't obviously screw with the hormones of human babies, but with rats, they don't feel so bad about doing that. So one thing some scientists have done is androgenizing female rats. So when a female rat is in utero, exposing her to higher levels of testosterone, and for these androgenized female rats, they show increased female-directed sexual behavior. So these female rats will then mount other female rats. There seems to be some evidence of testosterone exposure in utero with these differences. Another thing, the more older brothers a man has, the greater likelihood he'll show a homosexual orientation. And the reason that I talk about that here is it's thought that this is about the mother's body reacting to testosterone as a foreign agent. So the more sons she has, the more she has this testosterone in her body, and then by the end she's reacting to it and decreasing the amount of testosterone that last male child or later male children are exposed to. So some evidence of something to do with hormones related to sexual orientation. In terms of genetic differences, well, like everything else, genes play a role. Whether or not you like cheese is genetically influenced, right? But nobody's arguing about that. But for sexual orientation, it's a bit of a bigger deal, and it's probably not a single gene like most other complicated behavioral patterns. There's not a gay gene and a straight gene. It's probably some combination of genes. And one thing I think it's worth just kind of taking a second to talk about is that the GLBTQ community, gay, lesbian, bisexual, transgender, queer community, as a whole, is ambivalent about research looking at genetic differences in sexual orientation. There are some people that feel, okay, if they can find these genes and show, okay, well, we are born this way, then people finally get off our backs and stop persecuting us for being different. But then there are other people that are a bit more skeptical and say, well, even if they determine these exact gene sequences, they won't stop persecuting. They'll just have they'll come up with new ways to persecute and say, okay, here are the genes, these are mutations, these are unnatural things that have changed in you, and we've got to figure out how to fix these genes in kids before they grow up. And I think the latter group is probably right, that determining clear genetic evidence for sexual orientation won't make some people any less comfortable with other people who have a different sexual orientation than themselves. Because for them it's not about if it's biological or not, it's about something else, which they're uncomfortable with for a variety of cultural, religious, and probably personal reasons. But genes play a role, like everything else. And then another theory is the exotic becomes erotic theory. And this idea that kids, when you're little, kind of, and think about sexual orientation developing over the course of childhood. When you're a little kid, at first you play with everybody, but then around age 3 or 4, you begin to have, most kids have a preference for playing with other kids of the same sex. Boys don't play with boys, girls play with girls. And they develop some fairly stereotypic play preferences, where boys wanting to play more roughly with trucks and girls playing with dolls. And if you give some boys dolls, they'll use them as trucks or guns. If you give some girls trucks, they'll use them as babies. There are certainly plenty of exceptions to that, but on average there seem to be these typical differences. And because of those differences in play preference, boys tend to play with boys and girls tend to play with girls. Now some kids will play... I'm sorry, let me stop. And when that happens, the idea where the exotic becomes erotic is that boys play with other boys. They're around boys all the time. They're a boy. It's like, okay, that's not that exciting. But things that are different, that are novel from them, that they don't know much about, that are exotic, those are fascinating and attractive and stimulating. Right? So for boys to play with boys, they see these girls over here, they don't know anything about them. Ooh, that seems neat. Same thing for girls. Those boys, they're not like me. They're different. And that difference is what is attractive. So the development of sexual orientation comes from playing with people of the same biological sex as yourself. And because you're kind of bored with that, you become attracted to this other. So that kind of explains the development of heterosexual orientation. For homosexual orientation, the thinking is that some kids play with other kids of the opposite sex. So boys that play with girls, and girls that play with boys. And because of that, they don't feel that these other people are different. That they may feel that people of their same sex are different because they don't hang out with those people. And so they become attracted to them. They're attracted to what's different. And there's some support for this theory in terms of gender atypical kids. So little boys that like to play with little girls and like to play with dolls. Some of them develop homosexual orientations. Not all. Many of them develop a heterosexual orientation. Same thing for girls. Girls who are kind of your tomboys that play with boys and don't like to play with girls. Some of them go on to form non-heterosexual orientations, either homosexual or bisexual, but by no means all of them. So there's some evidence that for some people this may be true. But again, sexual orientation, like anything else that's complicated, is multiply determined. And for women at least, seems to be susceptible to ongoing changes. Okay. The last thing I kind of want to touch on about sexual orientation that I neglected to put in the slide is I would encourage you to think of it not so much in terms of a categorical construct as you fall in. Okay, you either fall into this box, which is heterosexual, this box, which is homosexual, or this box, which is bisexual. But think of these things occurring on continuums, two separate continuums. The degree to which you find yourself attracted to people of the same sex, and the degree to which you find yourself attracted to people of the opposite sex. So if you're high on both, you're likely to be termed bisexual. If you're high on just one, you're likely to be termed either heterosexual or homosexual. And if you're low on both, you're likely to be termed asexual, or you don't have any kind of emotional connections, sexual attractions to anybody, regardless of sex. And there's some research that suggests that this is a better picture of human experience. So that people, like everybody in the group that's called homosexual, there are differences with the degree to which they are attracted to people of the same sex, and there are differences in that group in the degree to which they attract people of the opposite sex. Same thing for people in the heterosexual group. There are these differences in the degree of their heterosexuality, the degree to which they're attracted to someone of the same sex, or also the degree to which they're attracted to someone of the opposite sex. So think of it as more of this continuous variable than a categorical variable. I think that'd be a more accurate understanding of the human experience. Okay, so moving on from sexual orientation to gender identity disorder, which is a disorder in the DSM, so we have criteria to look at. A strong and persistent cross-gender identification. So cross-gender identification means identifying with people whose gender is different than what's indicated by your by your biological sex organ. So a man feeling as if he is a woman feeling as if she is a man. Persistent discomfort with a sense of inappropriateness in gender role, so the kind of feeling like you're born in the wrong body. If you read interviews with some of these individuals, they talk about it feels like God made a mistake, that I wasn't meant to be this way, that something happened wrong somewhere along the line. And these individuals are not physically intersexed. An intersex, you may be familiar with the older term hermaphrodite, which isn't used anymore because it's a bit inaccurate. And there are a variety of ways of being intersex. Intersex in general, indicating this very diverse category of people who either have ambiguous genitalia, where it's not clearly male or female sexual genitalia, or they might have a combination of male and female genitalia. They might have, an ovary on one side and a testicle on the other. They might have these kind of genetic mosaicism, or genetic differences, whether that be XXY or XYY, a variety of other things, just where in some way they don't fall neatly into, okay, you're XY male and you're XX female. They're somewhere in between. So even something we think so much as categorical as sex, in reality, although in small numbers, it doesn't always occur categorically and occurs on this continuum. But if you're intersex, then you don't suffer from gender identity disorder. You are intersex, and it's this biological condition, and I guess the DSM assumes it makes sense that would cause distress and dysfunction because it's not clear what you don't clearly fall in one category or the other, but you don't get to get a psychological disorder for having that. So that's a rule out. And then the disturbance causes clinically significant distress or impairment in important areas of function. So again, if you're a man and you identify with women and you feel as if you're trapped in this body, and so you want to live as a woman and you're not intersexed, if that doesn't bother you and you're able to live that way successfully, it's not a disorder. Not a disorder. It has to cause distress or impairment. And again, depending on where you live, it will probably influence the degree of distress and impairment you experience if you have this kind of strong cross-gender identification. So, because of that, there's significant debate about whether or not this should be a diagnosis at all. Some people comparing this to the previous pathologizing of sexual orientation, saying this is the same sort of thing where, of course, people are distressed. They're not distressed about their cross-gender identification. They know who they are. They're distressed about living in a world that can't accept the way they feel about themselves. And if that's the case, then it shouldn't be, it's not, the pathology doesn't lie in them, the pathology lies in society. Significant debate about this. And in some ways it depends on what you think the diagnosis, the word diagnosis means. For those people who say, well, diagnosis means that you're identifying a disease, then the argument is very strong, no, it's not a disease, this is how people are. People say diagnosis is a label to apply to a cluster of behaviors that can be researched, then yeah, okay, this is fine, let's make it a diagnosis, because there are some people that are this way, and it's interesting to study them and learn more about humanity from people who are similar, and diagnostic labels help aid in the study of human behavior. So pluses and minuses to diagnosis. But one of the other big things is if it's diagnosable, what's the goal of treatment? So is it to address your persistent cross-gender identification and teach you to identify with a gender that matches your sex organs? Okay, I know you feel like a woman, we need to teach you how to be a man. I know you feel like a man, we need to teach you how to be a woman. You're XX and you're XY, and you have to be that way. Or could it be that the treatment is, okay, you have this distress because you feel like a man trapped in a woman's body. Well, let's make your body match how you feel. And we have sexual reassignment surgery. Right? So maybe that's the treatment. And for many people, that's the option that they choose. And it's a fairly long, expensive process. And people usually have to undergo psychological evaluation before they're allowed to get the surgery and the hormone replacement therapy that's needed. But there certainly does seem to be some evidence from a variety of sources that this isn't some sort of psychosis or pathology in terms of something that's a passing state that they'll get over. They seem to be different than other people. Male to female transgender men who feel that they're women score differently on a variety of measures, not just attitudes, but physiological measures. In some ways, their body and their brain looks more like women than men. Same thing for women who feel like they're men. In some ways, their brains look more like men's brains. So there does seem to be something biologically different about these individuals that supports their cross-gender identification. It's not just some weird thing, oh, you had this bad experience and now you hate your gender identity. That doesn't seem to be the case. It appears to have this kind of very strong biological component. And we've learned from some other very unfortunate incidents in the history of psychology and psychiatry that you can't change people's gender identity. You know, because a lot of people think, okay, well, when a baby's born, if it's a boy and you raise it as a girl, it'll be a girl. If it's a girl and you raise it as a boy, it'll be a boy. You can make people, you can make them have a certain gender identity. And we know that people have tried that from a few instances. Some with intersex individuals where it wasn't clear what their genitalia was. And maybe they had both, and the doctors, at the parents' consent, destroyed one set of genitals and enhanced the others. So they picked. So I don't know if you're a boy or girl. We'll pick this one. And there's is where they were wrong, and the person's gender identity didn't match the genitals that the doctors left them with. They matched the other ones. Then also we have, blanking on the name right now, but a young man who, during his circumcision, they ablated his penis. They mutilated his genitals on accident. And the doctor at the time said, well, we can't reconstruct it, but I think we can make him a girl. We can make this into a pocket, and if you raise him as a girl, he'll never know. Give him hormones, and he'll be a woman, and everything will be fine. And he grew up a very confused young man and eventually killed himself. And there was a psychologist involved that did some very unethical things. But from that case study and from other studies of interstate genders, we realized that it's really hard to change people's gender identity. However they're hardwired to see themselves, it seems pretty resistant to change, despite very drastic efforts to force change on people. Okay. Let's move on to talking from the kind of sexual identity, sexual occasion, onto the sexual dysfunctions. So, to understand sexual dysfunction, we have to first talk about how sex works. And I won't put up graphics here, but the sexual response cycle. So, not the mechanics, but what your body does during the sexual response cycle, if all things are going well. So it starts off with desire, right? So people have sexual fantasies, a desire for sexual activity. So before you engage in the behavior of sex, you have some level of desire, and you want to have sex. For normal individuals, right? For most, statistically speaking, most individuals want to have sex. If you don't, then we think, oh, something's different there. That's weird, because we assume that we're programmed to want sex. So there's desire, and then from the desire phase, if you encounter a partner, you may make it to the excitement phase, right? So now there's an object of your desire that you're beginning to interact with, and there's some physiological arousal. So at this point, what the body does, the blood rushes to the genital organs. In women, there's vaginal lubrication, so the body's getting ready excuse me, for sexual intercourse. And then, so begin the sexual behavior, and excitement, arousal's going up, and at some point you reach this plateau, right, where arousal continues to increase, but at a slower rate. So you're walking on the street, feeling pretty good, meet somebody, hey, let's go hook up, and then you get more and more excited, and your heart, all these measures of excitement are spiking quickly, and then they'll start to plateau. They'll increase, but not as quickly, toward a pre-orgasm maximum point. And so you can only get so excited before the sexual response cycle moves on to the next stage. But for some people, they stay in this plateau phase for longer or shorter. And then if things continue to go well, again, you reach that maximum point, and then you get to the orgasmic phase, and then you experience a rhythmic contraction in the sex organs, and in males, the experience of ejaculation. And then just a side note, to touch for a second on gender differences. Subjectively, orgasm seems to be similar in males and females. So the way they describe orgasms seems to be similar. And I bring this up, for one, because I think they use some really clever methodology to figure this out. So if you wanted to figure out, okay, for men and women, is orgasm the feeling of, not the biology of it, but how they feel when they orgasm, is it the same or is it different? How would you figure that out? Probably ask them about it, right? So you have a bunch of male responses, a bunch of female responses, and then you could go through and look for differences. Okay, well, they seem to be this, and these seem to look for themes emerging in the two. And that might work, but there will probably be some bias in the rate of the judges figuring out. What they did to figure this out was they asked people about the experience of orgasm. Tell me specifically what it feels like. Write it down. And they coded them as male and female, mixed them up, and then gave them to some other people who didn't know what the codes were, didn't even notice that they were coded, and said, okay, put the stack of paper here. These are male and females, men's and women's responses when asked what orgasm's like. I want you to put them into two stacks. One stack for women's responses and one stack for men's responses. And they found that people couldn't do it. They couldn't put them in reliably these two stacks. They would create two stacks, but they weren't right. They weren't reliably men in one stack and women in the other. And because of their inability to separate the two by looking at the descriptions, they said, okay, there's not a subjective difference. Okay, back to the cycle. Okay, so orgasmic stage, if everything's going well, but then you unfortunately can't stay in that stage forever, so you come to the resolution stage. So now arousal is coming back down to normal levels, to pre-plateau levels. And then there's this refractory period, a time during which further stimulation does not produce visible signs of arousal. And if you've taken physiological psychology and you know about neuronal transmission, this should sound familiar, right? A neuron, after it fires an action potential, it can't fire another one for a certain amount of time. There's a refractory period for a nerve cell, right? It has to do with the sodium ion pumps repolarizing the cell because it becomes depolarized after hyperpolarization. So there's a very kind of neurological basis to this refractory period, and seems to be longer in general in males than females. So that's if everything goes well. So now let's talk about when things don't go well. The sexual dysfunctions. Generally, a sexual dysfunction is some disturbance in this sexual response cycle. So either getting stuck at one phase or not moving from one phase to the next, or having problems in a certain phase. Right. So something that's why we talk about the cycle, or it's some pain associated with sexual intercourse. Right? So those are the kind of the two things that different disorders are going to meet one of those two criteria generally. Typically, a sexual dysfunction causes distress or personal difficulty, like any other disorder. But there's also that element of clinical judgment. So in terms of when we talk about premature ejaculation, it has to do with how long somebody is having intercourse before the male experiences ejaculation. Well, how short of time is too short? Right? For diagnostic purposes, up to the clinician. You lasted 5 minutes, that's plenty of time. 1 minute, plenty of time. Oh, only 30 minutes? That's not long enough, that's premature ejaculation. Right? So there is some subjectivity there. There aren't these hard and fast rules for how long you need to be in any phase of the cycle to meet criteria for these things. So clinical judgment becomes pretty important in identifying these things. We also know in terms of diagnosis, there are different subtypes, lifelong versus acquired. Obviously, lifelong being ever since you've tried having sex or masturbating, engaging in any kind of sexual activity, this has been a problem or an issue, or is something that happened at some point in your life. And usually when they're lifelong, one thing is they're frequently harder to treat, and we also assume more of a biological basis, and if it's acquired, we assume more of a psychological basis, especially if the acquisition of the disorder follows some traumatic event. And it kind of makes sense. Okay, well, neurologically everything's probably fine, but this is some sort of psychological process interfering with your sexual response. Generalized versus situational. So if it's some sort of arousal disorder, you can't get aroused. Is it only with a partner, and you can get aroused when by yourself, or is it all the time? You can't get aroused at all. So is it generalized, or is it just with certain situations, certain partners, with certain objects present or absent, or is it you can never get aroused or achieve orgasm or whatever the problem is? And all of that generally is related to the other subtype you can tack on there is due to psychological factors or combined factors. And you notice there's not just due to biological factors. If that's the case, it's not not considered a psychological disorder. So there's always assumed to be some psychological component. Whether or not that psychological component is accompanied by biological component or not will lead to slightly different diagnoses. But there's always thought to be some psychological component to the sexual dysfunction. Okay. So let's look at the dysfunctions. Hypoactive sexual desire disorder. This is when there's a deficiency or absence of sexual fantasies and desire for sexual activity. Right? So if we look at the cycle we talked about earlier, right, you can see excitement, plateau, orgasm, and resolution. Somebody with hypoactive sexual desire, unfortunately I couldn't get them on this chart, they wouldn't even make it to the excitement phase. Right? Because before excitement is desire, and they don't have the desire for sex. Not interested in having sex at all. Not that they're afraid of having sex. It's not like, oh, they want to, but they're afraid. There's really an absence of desire. one that's fairly similar to that would be sexual aversion disorder. So this is not just, I'm not really interested, this is an aversion to, an active avoidance of genital sexual contact with a sexual partner. Sometimes, usually experienced with some moderate anxiety, sometimes even panic attacks if they're averse to sexual activity. But again, people have sex for more than one reason. So you may be with a partner and you want to meet their needs, so try to have sex even though you really don't want to. And you may experience a panic attack because of that. Problems with this may be at the desire phase. So the aversion may lead to low desire, or there may be a desire, but because of the aversion, you can't get excited. And for some people, it may involve, they may get further than that, so they may get excited, but then the excitement is accompanied by anxiety, right? So they're, in some ways, they may be misreading their own body cues, where as they're becoming sexually aroused and excited, they're getting more anxious, and they okay, this thing is going to be horrible. And so their sexual excitement is interpreted as anxiety, and then it becomes unbearable to continue. Skip on there. Female sexual arousal disorder, persistent or recurrent inability to attain or maintain until completion of sexual activity an adequate lubrication, swelling response to sexual excitement. So basically, this is you can't get excited, right? Because remember, excited involves lubrication, the preparation for sex, or they can't stay in the plateau. So either can't get aroused enough physically, or can't keep their arousal level up. Related to that would be male erectile disorder, which is persistent, recurrent inability to attain, maintain until completion of sexual activity and adequate erection. So these two are thought to be generally the same disorder, which is the male version and female version. So it may be people that they have desire, they have excitement, but then as their body is getting ready for sexual intercourse, in women they're not achieving enough vaginal lubrication, and the body's not, the arousal isn't increasing the way it should. Men, same thing, the arousal isn't increasing the way it should, and so they're not able to achieve a full erection. The blood's not flowing enough to the penis. Or it could be that they have that initial push and they get the excitement up to plateau, but then they can't stay there. Right? So, because the goal, right, is to stay on plateau long enough to reach orgasm. These people, they're having sex and it's feeling good, but then it stops feeling good, and they can't get to the next level of orgasm, and so eventually the erection will go away, or again lubrication will cease, and sex will probably become painful or otherwise mechanically difficult, and they fail to achieve orgasm because of the problems maintaining arousal. Okay, so this is again the idea that they're not able to stay in plateau long enough. So again, how long are you supposed to be able to stay in plateau before you can reach orgasm? It's subjective, which makes it hard sometimes to differentiate arousal disorder, erectile disorder, from orgasmic disorder. So female orgasmic disorder and male orgasmic disorder involves persistent, recurrent delay in or absence of orgasm following a normal sexual excitement phase and plateau phase. So this is where you have that problem getting from plateau to orgasm. So arousal disorder, either there's a problem with excitement or you're only in plateau for a little bit. With orgasmic disorder, the idea is that you're in plateau for plenty of time. You have normal excitement, you're going at it, but you just can't reach that orgasmic level. So sometimes it's distinguished from arousal disorder in terms of the ability to get excited. Other times it's in terms of how long you're staying in that plateau level. With staying in plateau just a little bit of time, that's an arousal, erectile disorder. You weren't able to stay aroused long enough. Orgasmic is, well, you stayed in plateau a reasonable amount of time, whatever that is, but then fail to achieve orgasm. Persistently, recurrently. Not just once, but recurrently. Premature ejaculation, we've already kind of touched on. Persistent, recurrent onset of orgasm and ejaculation with minimal sexual stimulation, which is subjective. Before, on, or shortly after penetration, and before the person wishes it. So if you don't mind, not a disorder. And interestingly, think back to that kind of generalized versus situational, the majority of people with premature ejaculation can delay ejaculation while masturbating. So it seems to be a problem related to intercourse with another person. So it will be on our little graph C, right? So they get very excited, they're jumping up to plateau, and then boom, quickly going to orgasm and resolution before staying in plateau. And if we look back at B, the black line, that would be our orgasmic disorder, where somebody has normal excitement, stays in plateau, but never reaches that orgasmic phase and comes back to resolution. And then the A would be a normal sexual response cycle, where excitement, plateau, and then orgasm, and then for men, a return to resolution. For women, there's a possibility of return to plateau briefly, and then another orgasm, and then eventually resolution, right? Because again, they have that shorter refractory period. Okay. And then dyspareunia. This is where we get away from the sexual response cycle a little bit. This is genital pain associated with sexual intercourse. Probably a problem during the plateau phase, assuming that there was foreplay. So because the genitals don't hurt when they get aroused. It's only once intercourse starts. So that would be probably during the plateau phase. That's weird. Vaginismus. Can't get to show up. That's weird. But, hopefully you saw it there briefly. Vaginismus is recurrent, persistent, involuntary contraction of the perineal muscles surrounding the outer third of the vagina, which do contract normally during orgasm. But this is a recurrent, persistent, involuntary contraction of these muscles when vaginal penetration is attempted. And frequently it's vaginal penetration with anything. So when a woman goes to her OB-GYN and they try to put the speculum in, there's that contraction that makes vaginal penetration difficult or painful. This is probably problems at the excitement phase, where the muscles are contracting too early. But interesting, if no penetration is attempted, progression through the phases is still possible. So they can still get excited, reach plateau, and orgasm, but via other ways of sexual stimulation that don't involve vaginal penetration. Okay, so as you notice, looking at the cycle, there's never a problem with the resolution phase. There's never a disorder that says you don't reach resolution, you stay in plateau, because that probably would cause distress. Maybe dysfunction eventually, but it hasn't been pathologized for anybody who has problems returning to a baseline level of activity. That seems to be the body will always return to the preset levels. Homeostasis is the rule. Okay, so moving away from the sexual dysfunctions, which are again associated with either problems with the sexual response cycle or pain, one of those two things, we now move on to the paraphilias, the disorders related to attraction. So, for 6 months or more, you have intense sexually arousing fantasies, urges, or behaviors involving one of the following: either non-human objects, shoes, or the suffering or humiliation of yourself or of your partner, or involving children or non-consenting persons. And obviously this disturbance must cause distress or interpersonal difficulty to be diagnosed. So one thing that's interesting to note for the paraphilias is that it's one of the few disorders that doesn't require a behavioral symptom. Right? So you could have these behaviors involving these things, but it could just be the urges. So if you never act on it, so if you get turned on by shoes, but you never involve shoes in your sexual activity, you'd still meet criteria for a paraphilia if it caused you distress or interpersonal difficulty. So when would paraphilias cause you distress? If you felt that it wasn't right to be attracted to what you were attracted to, it might. And when would it cause you interpersonal difficulty? That's usually when, at least for the first two categories of non-human objects or suffering humiliation, depends on your partner. Right? So if you're a sadist and your partner's a masochist, probably not going to cause interpersonal difficulty. You both, one likes suffering, the other likes causing suffering, and you're a good match. If you've ever seen the movie Secretary with James Spader and Maggie Gyllenhaal, it's an interesting look at what can be a kind of a symbiotic relationship, and possibly, debatably, a healthy sexual relationship between two people, one who likes to cause suffering and humiliation in ways, and one who likes to suffer it. But again, if the two people together have no problem with it, not a disorder. You know, if you're into shoes and your partner likes to wear fancy shoes, spiky shoes during sex, it doesn't cause interpersonal difficulty, it doesn't cause stress, not a disorder. But then the other one, the children and non-consenting persons, that's a little different, because and this is generally because as a society we have an obligation to protect individuals from harm, especially children. So even in those instances where the person might argue that the child was consenting and that it doesn't bother the child, it bothers us as a society because we say children can't give consent. They don't have the cognitive, emotional maturity to consent to sexual behavior with an adult. So it's pathologized. In the non-consenting persons, that's also somebody who has fantasies about rape and acts on rape, and that can be a psychological disorder, indicative of psychological disorder. So in those instances, it doesn't matter if it bothers you or not. It's going to cause interpersonal difficulty because it's against the law. So if you act on those behaviors, if you just have the urges, even with children, somebody who has urges to be sexual with children, if they never act on it and they find a way not to be distressed about it, it probably won't cause interpersonal difficulty. Well, not probably, but it's possible that it won't cause interpersonal difficulty, and therefore wouldn't meet criteria for the disorder. Which again, are they different than somebody who acts on it? Maybe in some minor way, but do they both have the same disorder? I would argue yes, but they wouldn't both meet criteria, which again gets to the limitations of a diagnostic system. Just because somebody maybe has a collection of behaviors, if they don't meet all the criteria, the label doesn't get applied. Okay. Let's talk about the paraphilias. Exhibitionism. Oh, and let me stop 1 sec. I'm a bit out of order. In terms of who does this, if you look at people diagnosed with paraphilias, a gender split, men and women, what would you guess? Maybe 60-40, 70-30, 95% men. So this is something that seems to be a male thing, so possibly related to something to do with testosterone, maybe, but except for masochism, all the paraphilias are dominated by men. So it's very a masculine thing to have these urges. Exhibitionism is people who have the urge, desire to expose the genitals to a stranger, so that's how they get aroused. And the idea with these paraphilias is that not just, oh, that's how they get their kicks, and they can also go have normal sex. The idea is that it's causing problems because the only way they can get aroused, the only way they can achieve sufficient arousal to achieve orgasm is by engaging in this particular behavior or fantasizing about these objects or these instances. And that's what makes it, in some ways, that's what makes it pathological, is that you're not able to have other sex. And it's not that flashing isn't pathological in and of itself, it's that you're not able to have normal or healthy sexual relations. Fetishism, use of non-living objects, panties, shoes, whatever. But instead of a person, it's an object that leads to the arousal, and again can achieve appropriate level of arousal, can achieve orgasm without that object being involved somehow in sexual behavior. Frauderism involves touching and rubbing against a non-consenting person, usually in public. So this is if you've ever been in an elevator on a subway and somebody brushed up against you and it wasn't that crowded. That may have been them getting their sexual arousal going. And again, it's a non-cynic. There's something arousing to them about rubbing up to somebody who doesn't know what they're doing or isn't consenting to what they're doing. Pedophilia. Obviously, this is attracted to a prepubescent child. And again, they don't have to act on it to be diagnosed with it, as long as it causes distress or dysfunction. And in terms of, how old is the child? Well, for statutory rape, there are definitions that are based on age of the child and age of the perpetrator that differ by state. For pedophilia, it's just generally prepubescent children. So somebody who's attracted to just 16-year-old girls wouldn't technically be considered a pedophile, and it's probably different in many ways than people who are considered pedophiles, who are attracted to these children who haven't developed their secondary sexual characteristics, right? 'Cause that's what prepubescent means. Girls that haven't developed enlarged breasts, boys that haven't developed the hair under their arms and on their genitals. There's something about that, about before puberty, that's attractive to these people. So one thing to note is that not all child abusers are pedophiles. In fact, I'd say that the majority of them aren't pedophiles. People that are convicted of child sexual abuse, many of them have normal sexual relations with other people. And it's frequently a male family member having sex with a young girl. Sometimes prepubescent, often immediately following puberty, so 13, 14-year-old girls. And there are a variety of horrible reasons for child abuse to take place, but most of them aren't related to pedophilia. But of course, some people who have pedophilia are child abusers. Then not all pedophiles are child abusers, because not all of them act on their urges. Those who are able to not act, they're still pedophiles, but they aren't child abusers. So child abuse and pedophilia, not the same thing, but obviously related. Alluded to masochism earlier. Sexual masochism, people who want to be humiliated, beaten, bound, or otherwise made to suffer. Interesting, this tends to be rich people and powerful people. Rich, powerful, white men that, I guess, humiliate people all day and want to see what it's like on the other side. But again, can't get sexually aroused without doing this. Sexual sadism, being the other side of that, people who will get excited by the physical suffering of the victim, and the partner may or may not be willing. So it's not that the sadist gets off on hitting somebody who doesn't like to be hit. They might, but it might also be somebody who's a masochist who enjoys and also gets arousal out of that type of interaction. Transvestic fetishism. This is when typically a heterosexual male gets aroused by cross-dressing. And the data are a bit ambiguous about whether it's always heterosexual men, but in general, it seems to be the majority of people who have transvestic fetishism are heterosexual males that again get aroused by cross-dressing, and they don't. They may have gender dysphoria. They may have some discomfort with their maleness, but not necessarily. And again, they typically will dress them to be aroused, but then they'll still have sex with people of the opposite sex. So it's not related to sexual orientation. Although you may see gay men who dress as women, those are not transvestites in terms of transvestic fetishism. They're cross-dressers, and usually the reason for that is cultural entertainment, and they don't do it to get aroused. It's kind of a cultural phenomenon involving putting on shows. Voyeurism, people that get excited by observing unsuspecting individuals who are naked, disrobing, or having sex. And then if you don't fit into any one of those categories, you can be diagnosed with paraphilia NOS, not otherwise specified. So these are those other kind of rare and strange things people get attracted to. Necrophilia, coprophilia, they don't fall neatly into any particular category. But somehow you have this problem with normal sexual relations and your sexual behavior and arousal and attraction is restricted to one thing that's not typical and it's causing distress or impairment. Okay. So where do these things come from in terms of the sexual dysfunctions we talked about earlier? Varied depending on what the dysfunction is, and also within individuals, different causes. Frequently, there are other interpersonal or intrapersonal problems going on, of which the sexual dysfunction may be a symptom. So, for example, male erectile disorder, that may not be the problem per se. I mean, it's problematic, but it may not be the problem. It may be a symptom of some other problem. If a couple aren't relating in an intimate way, that may be the man's way of coping with that. Or sometimes in the treatment literature, read about men who experience a loss of power, losing a job or not getting a promotion at work, and then that translates into erectile dysfunction, which is a very kind of Freudian thing. The idea of being emasculated takes away the masculine sexual ability. But obviously, things like depression and anxiety can interfere with your sexual response cycle. So frequently, sexual dysfunction is associated with other intrapersonal problems, so you being depressed or anxious, or interpersonal problems, so having problems in the people or in the person you're trying to have sex with. It's a relationship problem that's manifesting in your own difficulty sexually. It might also be a medical condition playing some role, but again, to be a psychological disorder, there needs to be some psychological component to it where the medical condition can explain it fully. But men with prostate cancer, that obviously can play a role, and a variety of other medical conditions. In terms of the paraphilias, again, varied in terms of what causes it. Different things for different paraphilias, and also within the same paraphilia, different things for different people. In terms of family variables, we do know that an abuse history is somewhat common, more common in people with a paraphilia than in the general population. Not everybody with a paraphilia reports a history of abuse, but enough do that it's statistically significant and clinically significant. For many individuals with paraphilias and fetishes, they often lack social interpersonal skills. And the thinking goes that, okay, well, they lack certain social skills to where they aren't socially effective enough to engage in normal sexual relations. And because of that, because they've experienced frustration socially trying to, get sexually satisfied via the typical route, that their sexual energy has been diverted along some other path where they found an outlet or fulfillment. And then also related to especially the fetishes, learning theories may have something to say in terms of the association of objects with pleasure. So somebody who's maybe having normal sexual relations, and maybe the first time they're having sex, and there's some object in the room that they focus on for some reason, and they associate that object with their feeling, and then the object becomes becomes a stimulating event, and they have to have that object present to get aroused because of the associative processes of learning. How do you help people that are diagnosed with disorders that are having distress or dysfunction? Well, you might want to see a sex therapist, and I do kind of put here that sex therapy is a specialty. Most therapists are trained to deal with relationship issues and can help to some degree with sexual issues, but sex therapy is its own specialty. There's not a sub-license for it, but there probably should be, and I think extra training is required to work with these issues because they are very sensitive. Often people are embarrassed about these behaviors more so than other things. People that tell you all day long about their depression won't tell you about the problems they're having in the bedroom. So sex therapy requires an experienced, well-educated counselor. For the sexual dysfunctions, there are medical treatments, obviously mostly drugs that are designed to impact arousal and blood flow, hormones. There are also, for erectile dysfunctions, implants and pumps. If there's something wrong mechanically, there are ways of getting around that. Education and coaching. basically, one thing that sex therapists do is teach people about sex, about what we know about typical sexual experiences, and about what should be happening with your body, about what seems to be happening, and then teaching them how to have good sex. A variety of ways of doing this. One of the things that I always found most interesting, that sex therapists sometimes do, is prescribe people not to have sex. In couples, married couples, that would come in and talk about having difficulty initiating sex, telling them, okay, I want you to, this whole week, don't have sex. Whatever you do, because you're not ready for it, you have to do some other things. And when you do that, because of our kind of psychological reactance, people will go and have sex. And part of it is there's so much pressure on them to have sex. And we feel like we should be doing it, we can't do it. Once they're told not to, that pressure is taken away. And when the pressure's gone, their natural attraction to each other takes over. But there are a variety of techniques, again, that sex therapists are well versed in terms of teaching people, educating them about sexual practices, and then coaching them in how to have a more satisfying sex life. Treatment might also look at, again, dysfunction as a symptom of other problems. So instead of focusing on treating the sexual problem, focus on the other problems, focus on the depression or the anxiety or the relationship problem, and say, okay, we're not going to talk about your sexual problem right now. It is a problem. I know you both are upset about this, but right now we've got to figure out this other thing. And once we figure that out, I promise we'll come back to this. And what sometimes happens is when you figure out that, get some help with the originating problem, the causing problem, the sexual problem goes away. Because again, it may have been a symptom of some other problem. For the paraphilias, generally difficult to treat. Medical treatments may include reducing testosterone levels with certain drugs. Some of the SSRIs reduce sexual urges. And there's chemical castration where you can make it in men, usually, because again, these people who are doing it, you take away their testosterone to where they won't have the urge to have sex. And it works sometimes in some individuals. The problem is that for some of these people, their behavior becomes more than about sex, more than about sexual arousal and pleasure, and something more deeply entrenched and more pathological, to where even if they don't want to have sex, they'll still engage in paraphilic behavior, still engage in abusing children, because it's more than just about the sexual desire. So some successful treatments, but difficult, and obviously difficult to keep people on drugs that take away their sexual arousal, because we're wired to want sexual arousal. Psychological treatments, they're developing. A couple things. Aversion therapy. This is where if there's usually some fetish object or the object of their desire is inappropriate, trying to teach them not to be aroused by it anymore. So you would have them masturbate while imagining the arousing object. So for a pedophile, have them masturbate while thinking about kids, and then shock them when they do, so that you're pairing thinking about kids with the shock instead of being paired with the arousal of masturbation. A controversial approach, effective for some, but usually only people that are very highly motivated would do that. Related approach would be covert sensitization. This is where instead of shocking people, you just have them imagine negative consequences. Somebody who's an exhibitionist, have them in your office. Imagine exposing yourself, and people are all watching, and start to get excited and say, okay, now imagine them pointing and laughing and throwing things at you. And imagine feeling embarrassed and ashamed. So you have them pair negative experiences in their mind with their mental images of their fetishistic or paraphilic behavior. Another approach would be orgasmic reconditioning. So the first two are about kind of punishing, and this one, so you might combine those with this one. With orgasmic reconditioning, you may have them engage in masturbation. Again, starting with the paraphilia, so starting with imagining the object that's inappropriate, but then before they reach orgasm, have them imagine an appropriate target. So have them imagine another adult person rather than a child or an object. And then on top of that, you could have them again for men, after they've orgasmed, have them go back to imagining the paraphilic object and continue masturbating, which again they'll be in the refractory period, so it won't be rewarding and it'll be annoying and physically uncomfortable. So again, just basically trying to teach them to learn to associate sexual arousal and orgasm with appropriate objects, and to associate their inappropriate object with annoyance, pain, embarrassment, or any kind of aversive stimulus. But in general, paraphilia is difficult to treat. Most people don't come in voluntarily for treatment. It's usually through the frequently through the judicial system, referred for treatment, and so motivation is obviously a problem for many people. There are people though that may have fetishes that are causing interpersonal problems in their relationships with their partners. So they want to have normal sexual relations, but their partner finds out about their fetish and are not accepting of it, and then they'll come to therapy to try to deal with that. Limited success in helping those people compared to our ability to help with other problems. Okay, so we've talked about normal sexuality, that it's like many things, relative, what we consider normal. We've talked about sexual orientation, about what it is, how it develops, whether or not it should be pathologized. Gender identity disorder, which has to do again with that feeling as if you're in the wrong body. Talked about the sexual dysfunctions and how they relate to the sexual response cycle or pain, and then talked about the paraphilias, which are sexual arousal disorders, being aroused by the wrong kind of thing. Okay, well that's it for now. Take care.